Good afternoon, everyone, and welcome to Grand Rounds. To those in the virtual room, thank you for your patience as we sorted out my IT woes. And to those of you watching on YouTube, you've no idea what we're talking about. My name's Tom Farden, and I'm the chair and organiser of Grand Rounds. And as we delve into the autumn semester for 2024, we have a range of different presentations from a range of people before, and then some people we've not seen before. And I was dredging through the archives, and I don't think we've ever had a Grand Round presentation from the Scottish Ambulance Service. So this is a welcome first. So thanks very much for getting in touch with us and presenting today at Grand Rounds. So this is what it says on the screen right now: MacMillan Palliative End of Life Care Project, a partnership between MacMillan and Scottish Ambulance Service. I think those of us in secondary care, perhaps, well, I don't even say perhaps, I certainly have underestimated how much work goes on by the Scottish Ambulance Service of seeing people, staying with people, not transferring people absolutely appropriately, giving care on scene in people's houses. What the thing we call, I don't like the term, but it's called admission avoidance. I don't think that's is the right kind of term, but it's appropriate care at the appropriate time that doesn't involve transferring to a hospital. Huge amount of that goes on, and a large part of work that happens is people who are approaching the end of life. We know that the most of healthcare utilization of all of our lives happens, the bulk of that happens towards the end of our lives. So this is a really important topic, and I'm really interested to hear what Caitlin's got to say. If you have a question, please plonk it into the chat, or if you're brave, you can wait until the end, stick your hand up and say it in person. And otherwise, please keep your microphones muted during the presentation. And all that being said,
yes, Tom, thank you so much, and thank you to yourselves and Deans for inviting me today. I feel honoured to be the first Scottish Ambulance Service employee to come to Grand Rounds, so thank you so much. So yeah, today we'd just like to highlight some of the work that we're doing within the Scottish Ambulance Service to best look after individuals with both palliative and end-of-life care needs in the community. We have partnered with MacMillan in a project lasting for 3 years, which began in 2022 and will sadly come to an end, hopefully not come to an end, in March 25. So we're waiting to hear about some of our funding and things at the minute. We have just been so incredibly grateful for the work that we've been able to do with MacMillan and just that collaborative approach to looking after this cohort of individuals. So yeah, we at SAS, we want to provide patients with the best care that we possibly can, and usually that is in that crisis moment where we have really limited information about them as a person, what's important to them, who are they known to, where are they at within their journey, and we have to piece all those little bits together, and that's quite a challenge, especially in often the out of hours and often in that crisis point. So this is our team, so there's 5 of us all together, so there's 4 of us actually are paramedics. So Scott, who's our programme lead, Kerry, who's our lead in the north, Robbie, who's our lead in the west, and myself, I cover the east, and within that is obviously Tayside. We have 1 token nurse in the team, who's Sandra Campbell, who some of you may have met in some capacity before. So I cover Tayside, Fife Borders, Lothian and Forth Valley, and like I said, we've all been paramedics for many years. I've worked in Edinburgh predominantly, but also for London Ambulance Service as well, and it's just been an incredible project. So our aim essentially is to improve the quality of care that the Scottish Ambulance Service provide to people with palliative and or end-of-life care needs by March 25, but hopefully longer, by adopting that whole system approach to care delivery. And what this also means for us is reducing the number of people that are taken into hospital in those last days and those last hours of life where death is expected, and to reduce the number of futile CPR attempts that we make in the community and allow for that natural death. Now, obviously, you know, like Tom's already alluded to, that we do keep a lot of people at home, and about 50% of the patients that we see in all health boards actually in Scotland are able to remain at home. Certainly in Tayside, we've got a really fantastic network of pathways and professional advice that we can rely on to make that happen for people. But that doesn't mean the hospital is bad, and that certainly doesn't mean the ED is bad. So actually it's about trying to understand what is important to that person. And if that is to be cared for, or their preferred place of care and death is at home, then what can we do to make that happen for that individual? So some of the key components of our project, so pathway, so what that means for us is putting together some specialist palliative and end of life care telephone lines so that ambulance clinicians have that support, hopefully in 24 hours, which we do in most areas. But actually, how do we empower them to pick up the phone and say, I think this person's dying, and I think this is what we need to do, and how do we do that, and how do you support me in achieving that going forward? And we'll have a look at what that means for Tayside just in a wee second. Hospices, so we work alongside every hospice in Scotland. We've been welcomed with open arms, which has just been incredible, and a lot of the pathways that we've put in place are linked into the hospices as well. Massive care home work, so we work really closely with a couple of the other teams within Scottish Ambulance Service. Everyone has a real invested interest. So actually, for individuals in care homes, what's important to them? What is their future care plan? We know that it's really detrimental for a lot of people that reside in care homes to spend prolonged times in ED, and then obviously in the hospital in general. So actually, what can we do to facilitate that not being the end goal where appropriate? Education, so this is probably the biggest component of our project. So speaking to anyone that will listen to us, essentially, so we provide education to lots of different groups, obviously predominantly within the Scottish Ambulance Service, to all our staff through CPD events. We're embedded in sort of inductions, so our newly qualified paramedics coming through and our new ambulance technicians coming through. But we also work with all 5 universities in Scotland that offer paramedic programmes as well. So we're embedded ourselves right at the beginning of their education. So that's been great. And then just in case medications, we will touch on that a wee bit later, but all of our SAS clinicians can now administer just in case medication. So that's the patient's own if they are prescribed, which is great. And if they're not prescribed, then we can give SAS stock, morphine and midazolam again, and we'll touch on that in a wee while. So where are we now? So between 2022 and 2024, we have been very busy rewriting guidelines, updating policies, providing all that education, putting nearly 30 new pathways in place that we discussed earlier, and really trying to dig into those data sets to say, well, what does this actually mean for us as an ambulance service, and what can we do going forward? Because actually this cohort of people, this cohort of individuals we will see so much more and more and more of these types of patients in the community, so we need to do better. Where do we want to be? Well, we've got a vision of a model that we want to continue this work in some capacity going forward, and we just really, really hope that that's the case. There's so much work that we are ready to get our teeth sunk into. And how do we get there? So it's that outcomes focused work, isn't it? So we'll look at some of the data sets that we have been gathering. We have built a business case that's gone in last week. So yeah, fingers crossed. So just to have a look at some of the data, we've been working incredibly hard on this for quite some months now, and we've now got some data that we can publish, which is really exciting. So we worked really closely with some of the teams at Scottish Government to align our data sets with theirs, essentially. So looking at individuals whose cause of death, so essentially their ICD-10 code. So we've categorised them into 3 categories. So that cause of death as cancer, or frailty, progressive neurological conditions, or organ failure. So conditions that, those 3 causes of death that we can say are absolutely people who've been living with palliative needs up until their death. So when we looked at those individuals for us that we have had, that we've attended in the last 3 months of their life, so that 30 to 90 days, it accounts for 5.4% of our total workload currently. So it's quite substantial, really, when we think about that. And this is just the cohort of people that we absolutely know have that cause of death as one of just these 3 absolute palliative conditions. And then just widening that out to 6 months, so people that we see that die of one of these conditions within 6 months of SAS attendance was 6.9%. We've just done a whole data cleanse in the last couple of weeks on this data set. We felt that we were missing, and we were. So we worked really closely with our business intelligence team, and again with data analysts at Scottish Government And we've actually got a figure of 8.9, so nearly 9% of our total workload is individuals that we attend who die within 6 months of us attending, who have one of these causes of death, these three here that link with ICD-10 codes. And these numbers, I guess, relatively speaking, might seem small, but actually for us as an emergency ambulance service is really quite significant. And if we think about our total call volume, so we receive around about 5,000 calls a day into the emergency service in Scotland, and actually only about 14% of those calls that we receive to 999 are considered to be immediately life-threatening. So there's that whole other 86% of patients that we see who aren't in that immediately life-threatening category, that are often this type of patient, people living with life-limiting irreversible conditions. And how do we look after them, and how do we listen to what is really important to them and try and meet their needs? So for Tayside specifically, so we looked at data from January to December 2023. People that fit into this category, so this now 8.9% of individuals, was 3,442 people within that year that we saw that died of one of these three conditions within that 3 to 6 month period. So that's quite significant, really. So yeah, we just break down some of that data a wee bit further there. So of that number that I just mentioned of the individuals that died within that 6 months, actually 1,178 of those individuals died within 7 days as well. So again, that's really substantial. And what we want to figure out is, of those people that died within 7 days, what did we do? So actually, what was our involvement? What information did we have? Was there future care planning? Was there plans in place for what would happen in this eventuality? Or did we take a lot of these people to ED, which is often the case because we weren't really sure what else to do with them? And actually, what were their wishes? And was that therefore a good death or not? So yeah, really interesting. We're working with a health economist just now who's based in Belfast. That work's been incredible. I know we don't like to talk about the economic cost of really anything we do in healthcare, but obviously it's really important when we're thinking about a project like this. So we are looking to quantify, well, actually, what does all of this work mean? So, teaching ambulance clinicians to be more confident and have more empowerment to recognise the dying individual and to make those phone calls to try and facilitate it at home. Well, what is the cost of that? And actually, we're currently looking at millions and millions a year. We're looking at about 2.5. Currently, million, we're yet to publish that, hopefully in the next month. So I would love to share that with you when I have it soon. The other bit of data set that we're looking at just now is actually of all the people that we attend on a day-to-day basis, who can we determine as living with those irreversible, life-limiting conditions? And we've got a figure of 25% currently, so that those 25% of our total workload, we can see on a daily basis, are people in that category. So actually, many of them living with multimorbidity, but certainly those living with those life-limiting, irreversible conditions. So that's a quarter of our workload, which is huge. So why is palliative and end of life care important to ambulance clinicians? And actually, we're often asked this. We're often asked this by our own staff. When we do education sessions, and they say, I'm a paramedic. This wasn't really my bag. And when I went to university, I learned about car crashes and all this scary stuff that we think that is very paramedic-y, but actually we know that that's just not the case anymore. You'll be glad to hear that's not a picture from my camera roll. I just stole that from Casually. But yeah, none of you will be surprised to hear that the calls to SAS have increased, and like I said, it certainly accounts for 25% of our total workload for people living with palliative care conditions. And we all know, don't we, that annual deaths are expected to increase. So thought to be by 13.6% by 2040, and 94% of total hospital admissions in the last 6 months of life are an emergency, and around 90% of hospital deaths occur following that acute admission, often from ourselves. So there's a multitude of reasons for this in there, and we all know a lot of these reasons already. I don't necessarily need to spell this out to you, but there is an increased demand, isn't there? There's increased demand throughout the whole of the NHS and all of the services that we provide, but also that expectation as well of of what can happen, when a clinician gets involved. Multimorbidity, I've already mentioned it. I'm a bit obsessed with multimorbidity and what that means for us in an ambulance service, but we obviously know that has a huge impact for all of us working in healthcare. And with that, often multimorbidity and that aging population is that more complex disease management. Again, for us, that can be challenging. So people are living longer, but they're living a lot sicker. The lack of future care planning conversations, or the lack of us being able to access those future care planning conversations that might have already taken place is difficult. And then just a general sort of unfunding and lack of community services as well, which I'm sure you'll all be very familiar with. So historically, this wasn't really our bag. So calls to ambulance service were predominantly from those acute, sudden, unexpected events. But we know that that's just not the case anymore. And like I mentioned before, we can attribute only 14% of our workload to those immediately life-threatening situations. So change of workload, I've just popped this in just to highlight some of what I've just said, and I'm sure this will ring true for a lot of you as well. So we're not alone in this change of the scope of practice of paramedics and ambulance clinicians. Our profession, like so many others, has evolved significantly. And I've just taken a wee snapshot of, some of the articles, some of the textbooks that are out there for us to refer to, and not super new. Some of both the books that are on the end there have been written within the last sort of 3 to 5 years. And it's just recognising that a lot of our colleagues still feel really quite uncomfortable about how to care for someone in that end of life because it feels really quite alien to them. Yeah, so it's also quite new for a lot of people. Pathways development, so I mentioned earlier, we have now pathways available in every area, which is great. So we've got 23 active, ready to go already. So the way that our clinicians are able to access these is we've got what we call a GR Calc app, which is essentially like the ambulance Bible. You'll use the GR Calc every single day when you're with patients. It holds all your information about medicines that we give, all our guidelines, our algorithms, all that stuff that we like, all that black and white stuff. And within this, it's our pathways section. So the crews can go onto that and flick down into what area they're in. So for Tayside, we have that 24/7 access with Roxburgh House, which is great. And actually, what we do encourage our clinicians to do is to follow that stepwise approach. So actually, maybe it is more appropriate to contact in Tayside Consultant Connect, which is fantastic. We'll have a look at that in a second. But maybe it is more appropriate to speak to the patient's own GP and try and get some help that way first. But actually knowing that there's a specialist in palliative and end-of-life care when that patient is in that crisis and you just can't get a hold of, you need to get a hold of to reduce some of that distress and suffering, or just to bounce those ideas off, just to have those healthy conversations to say, I think this is what we're doing right now, and I think that this is appropriate. Can you provide me with some more information? Or are you able to have a look on Clinical Portal or ECS or whatever it is that you've got access to and just be able to support some of this decision making? So just mentioned that there. So Tayside Palliative and End-of-Life Care Helpline. So it's available to our crews 24/7, and they've got just a couple of different numbers there for in hours and out of hours. But it's just fantastic. We have so many examples of really good, really appropriate phone calls that have come into this line, which have then resulted in lots of different things. So maybe a direct admission to hospice if appropriate, maybe just that advice on just in case medications, whether they're prescribed or not prescribed to the individual, and just to provide that support and actually that ongoing care. So, an emergency ambulance crew are there in that crisis point, but actually we need somebody to look after that patient there going forward, so that crew can retrieve from that situation. So it's just been an absolutely fantastic. We worked really closely with both Deans and Eleanor Brabham as well. I'm just so grateful for that help and support. Just a couple of examples here of where that's worked really, really well. Just a wee case study in the bottom there, which I just think was perfect, where there was a 56-year-old gentleman in the Tayside area. He had pancreatic cancer, and his friend went to visit him, realised that he was really lethargic, really short of breath. He was incredibly frail, and he just was not coping at home. So the friend contacted the district nursing team, and they advised to phone 999. The crew got there and recognised that actually this gentleman was really unwell, and his preferred place of death was Roxburgh House. They were able to pick up the phone to that line that they didn't have access to previously and just discuss some of their concerns with the consultant that was on call at that time. And actually there was space in the hospice for him that day, and the crew transferred him to the hospice, and he died a couple of days later, really peacefully, in his preferred place. When I spoke to the crew afterwards, they said, if we didn't have that phone number, we just would have absolutely taken him to the ED. There's no doubt about it. And that's not to say that he wouldn't have had a good experience within the ED, but actually we know that his preferred place was Roxburgh House. Um, and so that was perfect, wasn't it, to be able to take him there. And if he was to go to ED, it's just that knock-on effect, isn't it? It takes some time for Roxburgh to be aware that he's there and all that sort of thing. So yeah, really, really positive. And then just some really nice feedback from our crews as well after they've been to these jobs. So just saying that this pathway is such a great opportunity to be able to give the patients the opportunity to get the right care, the right time, the right place. So yeah, all the ambulance staff in Tayside are really, really grateful for it. Future care planning. We are working incredibly hard to have better access for our ambulance clinicians to future care planning. Quite often when our staff are en route to a job, they won't even know the patient's name a lot of the time. They don't have a date of birth. They have very, very limited information as to what they're going to. Especially thinking about that palliative situation, that end of life type scenario. We don't really even have a code for that in the ambulance service. So often they'll be getting sent to breathing difficulty, an unconscious, a seizure, or and actually when they get there, they're unraveling all of this information as to what's actually been going on. We now have access, or we have had for quite a long time, access to ECS. And within that, we can see the KISS summary, so the key information summary, which is updated by the GP. So we're really heavily relying on GPs filling out that information as best as they possibly can, so that ambulance clinicians can access any future care plannings that has been made for that individual. So that's really powerful. The other thing that we've now got access to within that same ECS platform is digital access to Respect. So if the patient has a Respect form and it is uploaded to that digital platform, then the ambulance crews can see that on scene now. So again, it's just really powerful to be able to see that information exists. Another change that we've made, which comes into play hopefully in the next month, is that the terminal in the front cab of the ambulance, if the call handler does all the great work that they do in the background and they're able to recognise the patient's name and get a date of birth and they match up, whilst the crew are en route, the ECS button will just flash if there's a Respect and or a DNA CPR for that person. And it's just saying there's probably something you want to look at before you get there. So again, it's just about that information gathering that we've not historically done very well. We just haven't had access to these digital platforms. So that's really exciting. But for us, future care planning, whatever that looks like in whatever capacity, is just so powerful for us to help make decisions about people. So I mentioned some of the education that we delivered earlier. So like I said, we're in all 5 universities. I was at Queen Margaret last week, and I'm going to Stirling next week, which we love. We love being able to go in and have these conversations with the future with our new paramedics. So we do courses in recognising the dying patient, fundamentals of palliative and end-of-life care, symptom management at end of life, and actually how to administer subcut injection, which when I speak to a lot of the nurses in hospice, they think like it's quite funny because they say, oh, paramedics do IO, and drill into bones and all this sort of thing and intubate people, but actually, again, can feel quite uncomfortable, but just delivering those tiny little dosages of just in case medications. So we do a lot of support and education around about that. And confirmation of death and managing death in the community is another couple of sessions that we do, which are really impactful. So again, when I was mentioned right at the beginning, how do we encourage and give people the confidence to make decisions about when to start CPR and when to not, even in the absence of a DNA CPR? So we do a lot of support around that to reduce those really unnecessary, undignified attempts at CPR. If everybody that should be for a DNA CPR had a DNA CPR, that would be great and really helpful, wouldn't it? But actually, they get lost. We don't know where we are. We don't have access. The family don't know about them, or they're just not in existence in the first place. So, yeah, really, really powerful. And then we've got our e-learning modules now as well. So we've got 6 2RAS modules, and we have a mandatory learning day called LIP within SAS every year, which takes place, it starts next month actually. So all of our crews will have the whole morning session is around palliative and end-of-life care, how to recognise that dying patient, how to administer just in case medications, how to have those meaningful conversations with specialist teams to continue that care going forward. So we're really looking forward to that. So we're actually nearer to sort of 4,000 formal education delivered just now, but actually we will capture every single SAS clinician within the next year. So just in case medications, I'm sure you all know what they are. So they allow the patient to remain at home often and reduce those unnecessary hospital admissions, reducing those painful and distressing symptoms and allowing the family and the patient obviously themselves to feel involved in the delivery of their care. Just a bit of a history for us. So back in 2019, our advanced practitioners, so we've got advanced nurse and paramedic practitioners that work for SAS. So we changed the guideline that they were able to administer a patient's own prescribed just in case medication in the community. And of those individuals, it was very, very small numbers. I mean, our AP cohort is pretty small anyway, especially in some areas than others, as you can imagine. And actually only 30% of those people were still able to remain at home. So super small numbers, not very effective. And then in 2020, we all got quite busy, didn't we, with COVID? And we updated our guidelines to meet that demand. So actually paramedics, who are obviously registered healthcare professionals as well, were also able to administer a patient's own prescribed just in case medication. But at that time, like I say, we're all pretty busy and there wasn't any education or really any support around about that. So again, the numbers of medications that we were delivering, even in the midst of COVID, were pretty small, because the confidence levels of the clinicians just weren't there. Then in 2022, obviously, our MacMillan project began, and just last year in 23, we updated the SAS PGD for morphine to include the administration at end of life also, so we can give our own SAS stock medication where the patient isn't prescribed their own GIC medication. So that was really powerful. And then this year we've had a couple of other medicine updates as well. So we can now give SAS stock midazolam, which also sits with its own PGD that all the staff have to sign off, so that we can again use our own SAS stock medication where those medications aren't prescribed in the first place. The other medicine update that we have, which we're really excited about, is about 50% of our staff who work on the road, as they say, out and about in ambulances, are actually ambulance technicians. So they're non-registered healthcare professionals. They generally work with paramedics. However, for a whole host of reasons, quite often technicians will work together if their crewmates are sick or maternity or overtime or whatever reason that is. So we've now updated our guidelines so that our ambulance technicians can administer patients' own prescribed just in case medication with that top cover support. So if they are working together in an ambulance, they recognise an individual's dying, they recognise that there's a symptom that they want to manage, they can pick up the phone, have that top cover support from a senior clinical decision maker and administer that medication. And that's so powerful to just reduce that inequity, isn't it? Dependent on where people are, especially if we think about our geography in Scotland, some of our really remote and rural areas that might wait hours potentially for a paramedic, a nurse, a doctor, a somebody to come and back them up. So actually, it will allow our crews to be able to reduce some of that suffering. So that's really quite new for us. We're the first ambulance service in the UK to have been able to achieve that, which is huge. Yeah, and we have had a few instances already. One, which I discussed yesterday with the crew, actually, it was really powerful, was a double technician crew that happened to be working together in Skye, who attended a patient who was super remote. And yeah, they were able to administer some of those medications. And like I said, otherwise they would have waited hours and hours for that support. So here's some of the figures from July, actually. So the total number of just in case medications that we gave as a service was 175 different medicines throughout the whole of SAS. And you'll see that we pie chart on the side there. So that just highlights how many times we give a patient's own just in case medications and how many times we're using our own SAS stock. So currently about 70% of the time, so the vast majority of the time, we give SAS stock medication. And only about 30% of the time do we actually administer a patient's own prescribed just in case medication. And that's quite consistent every month now. That 70-30 split is really quite consistent. And I think that just paints a massive picture, really, doesn't it? Is that we come in that crisis point where often that support and that care isn't in place already. And thinking back to those figures that we looked at with aging population, more people, choosing to die at home where possible, that figure might widen and widen if the support from the relevant services aren't there. And just looking back to say June, sorry, it is July, of all of those patients that were delivered medications, only 4 of those patients were actually conveyed somewhere, so actually left their home, and they were all super appropriate. So 2 of them actually went direct to hospice. One went to a ward, which had been organised by the palliative care team, which was super appropriate, and one was a repatriation all the way from Edinburgh to Bournemouth, actually, which wasn't very pleasant for that individual, I can't imagine, but that actually all needed to happen and all super appropriate. So that's really, really positive. So just to summarise some of what I said, so this has been a major project for us in SAS, and we're just entirely grateful to the wider MacMillan team, but also all the teams that we work with, especially in Tayside, Roxburgh. We've got such good relationships there, and actually this work wouldn't have been able to go ahead without that support. That collaborative working is absolutely essential for us, and we are now more than ever completely focused. Our outcomes are completely focused on the data that we're managing to collect now. But more importantly, the work that we are doing and going forward will hopefully improve the patient and carer and staff experience, as a massive impact. A lot of these situations on our staff as well, and reduce the number of bed days occupied in the last 6 months. And that is all from me, actually. I feel like I whizzed through that, hopefully not.
Thanks very much, Caitlin. That's brilliant. Absolutely fantastic talk. Thank you very much. And I've checked again, you are the first Scottish ambulance person
good.
who's presented at Grand Rounds in the last 11 years. So that's not bad, is it?
That's great.
I'm reminded actually of a Grand Rounds from some years ago. It must be pre-COVID, because we were in the Ganachie Lecture Theatre, where we had the topic of conversation was about anticipatory care planning. I don't know if you were there, Deans. It was fairly heated, actually, a heated discussion about anticipatory care planning and who was responsible for it. And there was a plan to have a national ACP system, and then there was KISS, and then there was our NHS Tayside ACP system, and it all flew between a lot of different things. And I remember leaving that meeting being a little bit despondent that there was work needed done, a lot of work to do, and not now. So I think your work is absolutely fantastic. So thank you very much.
Thank you. Thank you so much.
Does anybody in the audience have any questions? Just pop up my chat window. As probably everyone discovered, Zoom decided to do an update to its interface 5 minutes before we all tried to log on, and so the buttons all look different. It doesn't look like there's any questions at the moment. One of the challenges we have in secondary care is that the best way to communicate with you and SAS and the rest is through KISS, because KISS is available to everyone, but we can't edit it.
Yes. It's not great. And actually, none of these systems talk to each other. Yeah.
Asking our GP colleagues to update the thing is asking them to do yet another thing, and they're very busy. And I don't know if there's an answer to this. There have been so many projects and pilots of, your ACP in the milk bottle, but then who has milk bottles anymore? ACPs in your key box, ACPs pinned to your fridge. And an ACP is only as good as how well it's kept up to date. And everyone has a right to change their mind. Your AC, often we find in respiratory medicine, ACPs go out the window at 2 a.m. when a patient wakes up being choked to death. So do you think it's getting better? Are we getting better at being able to provide ACPs for first responders?
I think we're all trying to get better at it, and I think everyone certainly has good intention. But I think for all the things that you just mentioned is that everyone's just so incredibly busy, aren't they? And like you said, we're just so reliant on GP for us in SAS anyway, updating that KISS summary. Some of our what we call our integrated clinical hub colleagues, so that's our colleagues that do a lot. It's all our advanced practitioners. So we've got over 25 GPs now that work for SAS, and our advanced nurse and paramedic practitioners who do telephone triage. They now have access to Adastra, and they now have access to a clinical portal. But they sit within our control centres, and actually it's even just getting the information to our crews on the road to say, phone them up and ask them, do you know, is there actually something in there that's a key little nugget of information that's really beneficial? And like you said, we're there in that crisis point as well. So, you know, similar to your respiratory patients at 2 in the morning, people are phoning us in a crisis. They've had to phone 999, you know, because they haven't felt that they've had any other choice. So often what is written out in a care plan at that point in that anxiety driven state is like you said, often goes out the window. And that's okay. That's fine. We just have to adapt to that.
Sue said in the chat, these initiatives are taking place at the same time as issues are arising with administration of opioids. Is there legal advice feeding into these developments?
Administration of opioids. Well, I mean, our paramedics administer opioids as part of their, you know, they're obviously incredibly comfortable with doing that. That's something we do often. You know, and there is a legal framework around about the administration of medications by healthcare professionals, not just paramedics, but the wider that are prescribed to individuals. We, I guess, for us within a service, have really quite robust and safe sort of check-ins. So that the colleagues must check with someone before they give medications and all that sort of stuff that you'll absolutely be used to doing. We actually haven't since the project started. We obviously keep a note every single month of the medications that were delivered. We actually haven't had any errors. Touch wood, said that, but you know, in that 3-year period, which is really positive. Our medication error rate in SAS is pretty small actually. Which is great because I think our clinicians are just so used to being in a strange environment and you know, having to check medications at silly times of the night in really quite high pressure situations. So that's been really positive for us actually. I hope that answered
Deans
that
has
question.
put a link. Yeah, you did absolutely. Deans has put a link into the chat. Deans, with your no context link, would you like to tell us what about your link?
Yeah, it was just in terms of future care planning and your questions around what work and what progress is being made. So there is a future care planning working group that's working at a national basis. One of the things you may have seen was a CMO letter changing the terms to future care planning from the previous anticipatory care planning or the English and Welsh advanced care planning. Part of the reason of that is to try and move it into a setting that's just about planning for the future as related to your health and well-being, and take it away from viewing it as something that relates only to the full stop of your life and your death and DNA CPR. So the National Lead for Palliative Care does also chair this group, but does it in a work stream that is separate from the current palliative care strategy that's out for consultation. There is a move and there's incremental progress, slow but incrementally forward, around getting electronic and digital solutions to whole system working here that fits the clinical challenges we all face. A lot of that, though, is hampered through either legislation. So KISS, for instance, is legally part of the primary care record and therefore has to be only written to by GPs. So you have to move away from that. And then the technology stuff. And the ambulance service has moved a lot to be able to read the KISS and not know where you're going, because it used to be you had to choose in it between your sat nav or reading clinical information on the size of the screen you had. So there's all these kind of practical stuff, but there's a lot of good working, and I think that change of tone and it's being integrated into the digital work stream now, I would hope we will get there, and I hope your despondency could have a degree of optimism based on incremental improvement expectations.
Sounds like Heisenberg's ambulance. You can tell where you're going, or you can tell what you're going to do when you get there, but not both.
Yeah.
So, yeah. My despondency has absolutely turned around. I mean, there's been so much work that's happened. I know about this group nationally, but it strikes me that there has actually been incremental work, and things are changing, and there is improvement. But heaven knows, I know the challenge of getting all the health boards to talk to each other and do the same system, and we do have an ACP system on Clinical Portal, don't we? I mean, and we were well ahead of a lot of people in having that, but it's double data entry for a lot of people. It's and often doesn't get done. And one of the things I've asked of in the respiratory community is that often in KISS there'll be an entry that says a patient has ACP. Full stop. And you go, well, that's great to know they have one, but what is it? And so we're trying to work out, is there a way that we through the respiratory pathways, can we make that more visible? But I think future care planning, so FCP, you're gonna have to start talking on the FCPs, but future care planning, something we all need to do, isn't it? And it's all about what we want rather than what if this bad thing happens. Okay, any more questions in the audience? Otherwise, I'll draw things to a conclusion. I'm just looking at what's next week. So next week we're back to infectious diseases. Who I can say? Deans is ready. Have you raised your hand on purpose?
I did, yeah. Just before you go, there's another link
Please,
there. Yeah. Another link there, Tom, for what I just mentioned. There's a new national palliative care strategy out for consultation. So there's a link there that you can both read it and contribute to the consultation, and it is absolutely relevant to secondary care. It includes some of the SAS work and the relevance of conveyance, non-conveyance, and attending to urgent palliative care needs in community, and very relevant for specialist palliative care and community-based palliative care. However, it is there to be shaped. So if there are thoughts sparked from today, and or when you have a good read through that, then please do submit in your thoughts. If the consultation document is off-putting enough to you that you don't want to do that, you can always ping me an email with a rant or whatever, and I shall pass that on.
Thanks so much. So next week, Simon Hilton and others. So Simon's from Public Health, and I know that that Nick Ray is going to be involved in infectious diseases. I'm going to talk about MPOX. And we had an MPOX talk last year, I think, when it became an emergent infectious disease, and we're going to have another talk on an update of what's happened since then, and what you need to do in terms of PPE if you suspect a case. What do you need to do about who do you refer to? What tests do you do if you think you've seen a case, and what the future is likely to look like for these sorts of emergent infections. So that's next week, same time, same place, and hopefully Zoom won't do another update at 5 to 1 on a Thursday, and I'll be able to join on time. Thank you very much, Kidlin. That was brilliant. I hope you come back to be a viewer as well as being a presenter, and do tell your SAS colleagues they're more than welcome to join Grand Rounds at any time. And if they're working, then they can watch all this on YouTube, on our YouTube channel, which we're creeping towards 1,000 subscribers. And I'm sure I become I'm sure it become monetized by that point, and I'll be able to retire and with a wash of money. Interestingly, one of our YouTube videos, I think, was the subject of a spam bot because it's been watched 155,000 times. Now, that's nice, but I don't think it's real. But it was nice to be trending, at least for a day. So there you go. Right, everyone, thanks very much. Enjoy your afternoons. Get back to work and enjoy your weekends, and we'll see you again next week for more. All right, take care, everyone.